Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices located in Ottawa are on unceded, unsurrendered territory of the Algonquin and Anishinaabe people. We are grateful to have the opportunity to be present in this territory. Today, we're delighted to bring you evaluating factors that matter for the sustainability of large-scale improvement initiatives, the case of lean in pediatric healthcare. As mentioned in the intro video, please type your questions into the question box at any time. I will prompt you via chat as well, and I'll pose the questions to our speaker at the end of the session. Now I'd like to introduce our speaker. Dr. Rachel Flynn is an implementation scientist, postdoctoral fellow at the Faculty of Nursing, University of Alberta, and at Child Health Evaluative Sciences and Centre for Nursing Research at Sick Kids in Toronto. It's my pleasure to pass the mic to Rachel.
Thank you everyone for joining me today. I'm really happy to be here to present to you on evaluating factors that matter for the sustainability of large-scale improvement initiatives. The research today that I'm going to present is on lean in the pediatric healthcare system of Saskatchewan, and that's one example of my work in the sustainability field within pediatrics. So just the presentation overview today. I want to talk about the need and importance for sustainability research, implementation and sustainability relationship, the case study that I'm going to present on lean sustainability in pediatric healthcare, the current state of sustainability evidence, what we currently know in terms of this field. And then I'm hoping that we can generate a discussion and some question and answers around sustainability in the pediatric healthcare context and perhaps some initiatives that you're dealing with yourselves in your own environments. So just a little bit about myself. I'm a registered nurse from Ireland. I've been living in Canada 8 years now, and I'm really passionate about quality improvement and sustaining effective changes in healthcare. And where that background came from and that interest was really from my clinical practice as a nurse, where I, in my first year, rotated across several units and saw lots of practice variation and also lots of great quality improvement efforts based upon the best research evidence. But it was constant change, constant implementation of initiatives, and really a lack of follow-up of how they were working well or not, and how we could sustain them if they were effective in practice. And that has led me to my research program in this field. So where's the knowledge gap, and why do I think sustainability is a very important area of research? So we know it takes at least 17 years for research evidence to be implemented and used in healthcare practices. We also know that there's been these drive for quality improvement in patient safety from the Institute of Medicine, World Health Organization, and other bodies such as the Institute for Healthcare Improvement. We also know that if we don't use best research evidence in practice, that has negative consequences for our patients. This has led to the drive of the fields of quality improvement, implementation science, and knowledge translation. My work situates within the field of implementation science, which is a body of science that tries to come up with the best methods and ways to increase that uptake of research evidence in practice. However, within this field of implementation science and knowledge translation, Despite great efforts, even when implementation is successful, often initiatives or interventions are not sustained in practice as expected or as wanted. They often adapt or may fail. And we need to be able to understand what's working well, what isn't working well. How do we actually sustain these initiatives or interventions that are effective and spread and scale them to a larger level? So what is sustainability? Sustainability is the continuation or integration of a new practice within an organization, whereby it becomes a routine part of care delivery and continues to deliver desired outcomes, whereby the ways of thinking and attitudes behind process and outcomes have changed, and the new practice has become the new way of working. And that definition is from the NHS sustainability model. And another recent definition, which I use, became from Moore in 2017. And they have 5 key constructs that make up sustainability. So sustainability occurs after a defined period of time. The program, clinical intervention, or implementation strategies continue to be delivered. There's individual behavior change that is maintained. The program and individual behavior change may evolve and adapt, and that is a really important piece that we consider, is that adaptation that may occur, and that the initiative or the intervention continues to produce benefits for both individuals and systems. So to apply my interest in sustainability research, I had the really exciting opportunity to look at the lean transformation that was occurring in the Saskatchewan healthcare system at the time. And that transformation has actually been coined the largest lean transformation in the world. There was a researcher, Dr. Thomas Rodder, who was leading a large-scale evaluation of the lean implementation across Saskatchewan, but no one was looking at sustainability, and no one was looking specifically at pediatric healthcare. And I thought this was a really interesting environment to look at, as they were actually building a children's hospital at the time based on lean principles. So just to give a bit of context of the lean implementation in Saskatchewan, it occurred in 2012, and it's where the Ministry for Health mandated this transformation across its entire health system. And this was done through an external company, and I'll get into that later. And just to acknowledge as well the funding agencies that did support this doctoral research. So the methods that I use to apply for this work, and if anyone is interested in these particular methods, we can discuss after, but just to give a quick overview, I used what is called a realist evaluation. So rather than looking at whether the intervention is effective or not, this approach looks at what works, how, for whom, in what circumstances, and to what extent. And that comes with the underlying philosophy that everything won't work, the intervention won't work the same for everybody, and it will be different in certain contexts, and people will respond differently to the intervention, initiative, or program differently, and that will have different outcomes. And this is configured using a context mechanism equals outcome. So that's really saying that in certain contexts, so for example, under certain leadership, where lean is implemented, people will respond differently. They may feel engaged. And how does that feeling of engaged then lead to increasing the likelihood of successful implementation and sustainability of the lean implementation? So the design I used was an explanatory case study using that realist evaluation framework. I conducted qualitative realist interviews because I wanted to understand from various stakeholders, from their perspectives, what either hindered or facilitated the sustainability of lean in their settings. I conducted 32 interviews with multiple stakeholders across 4 pediatric cases. So I wanted to represent different settings within the pediatric environment. And I also wanted to understand the perspectives from parents, healthcare providers at the front line, unit managers, and senior leaders within the health system to gain those different perspectives. And I conducted data analysis using that realist evaluation framework. So really understanding how lean worked for whom in what context and how that facilitated or hindered sustainability. So some demographic findings: we had 9 registered nurses, 5 unit managers, 4 physicians, 4 allied health professionals, 2 clinical nurse educators, 2 care assistants, 4 senior leaders, and 2 parents involved in the dataset. I also wanted to understand what exposure these participants had actually had in terms of lean activities. So 75% had received the Kaizen basic lean training offered through the organization. It was my understanding that everybody was to receive this training. However, that did change as the implementation went on throughout the years. The most prevalent lean activities were visual daily management huddles, visibility walls and wall walks, and 5S events. Lean involvement responses range from 1 to 6 years ago. The most common response was approximately 3 years ago, and 88% of participants were aware of lean events currently taking place in their unit. So that does show that there was that small percent that weren't aware that lean was happening in their environment. So my research findings. The first finding really that came out from this work, and it was a 3-phased, I should say, study, and I'm focused today on the third final phase. But what really came out from this work was that ripple effect between implementation and sustainability, so that there is a clear relationship between these two areas, between implementation and sustainability, and how outcomes at implementation really shaped then context for sustainability. So for example, if at implementation participants felt engaged in the lean process, that then became a context for sustainability that would increase the likelihood of supporting sustainability. The key research findings that came from the interview were this ripple effect that I spoke about, the nature of implementation, the lack of fit and customization to context, innovation fatigue, the positive and negative effects of customization, and shared values and sense making. So I'm going to go through each of those research findings now. So the nature of implementation and the ripple effect. So one quote here was, "I think people definitely like the idea, but a lot of people are against it because of how it kind of was presented and rolled out. So I think there's a lack of understanding of what lean is." So what I found was that the early stages of lean implementation, they were funded, mandated, and top-down in nature. They were driven by an external consultancy firm that was outside of the Saskatchewan healthcare context, and that company initially focused on training senior leadership. Therefore, frontline staff in our interviews did not feel involved in lean changes, and they felt pressured to adopt lean. The lean language used did not make sense to staff, and this led to misunderstandings and negative perceptions of lean. There was a resistance, therefore, to lean and a lack of support for lean and potential staff retention issues. This had a ripple effect on context for sustainability. So what I'm trying to illustrate there is this relationship of how you tackle any program or initiative at implementation has a knock-on effect on that context to either support or hinder sustainability. So the second one was a lack of fit and customization to context. And the quote was, "From what I know about lean, I don't really support it. It was a model that came from industry. Healthcare is much more complex than industry. We're not making widgets on an assembly line. We're dealing with people in life and death events in this unit. They're children. So to try and minimize things and put it in an industrial model, I think is illogical, if not cruel." So lean comes from the Toyota production system and industry. So therefore, some of the participants found that that didn't really link and relate to the children that they were caring for in their healthcare context. The next was innovation fatigue. And one quote to support this was, "You know, it's difficult for me to figure out what's done because of lean and what was just changed on this unit, because I feel like we have so much change that I don't necessarily know what was changed due to lean." So lean was implemented in areas that experience constant change. Early stages of implementation involved multiple lean events for training purposes. Frontline staff felt overwhelmed from the constant change. They were unsure what changes were due to lean and felt that lean was the latest fad, and this led to negative perceptions of lean, resistance, and a lack of support by frontline staff. The fourth finding was about positive and negative effects of customization. And one quote to support this was, "I think there's a negative sort of view on lean as a whole. I think it's seen as something that, or at least my perception of people's perceptions, is that people view it negatively. That has sort of affected and negatively impacted how we do work around the hospital. That's just a general sense, is that people are annoyed by it. That it's made getting and accessing resources, equipment, those types of things more challenging." And that's just what I hear from nursing colleagues. And this is interesting because lean, for those of you that aren't familiar with lean, is intended to do the opposite. So it shouldn't make getting resources and equipment more challenging. If anything, it should make that process more efficient. The contract of the external consultancy leading the lean implementation ended before its time, and this then placed the continuation of lean onto the internal senior leaders and unit managers. So when that shift happened, this led to a process of customization of lean to the local context through a variety of ways. So in my research, I saw that they dropped the lean language, they did less lean activities, they had greater involvement of frontline staff. This customization of lean and shift in implementation triggered both positive and negative responses for frontline staff, unit managers, and senior leaders. And this is where I really saw differences between the different stakeholder groups in the data set. There was a variation and discrepancy between senior leaders and unit managers compared to frontline staff on how their perceptions of how embedded lean efforts were and the degree to how much they supported the continuation of lean. And this again was interesting because in implementation, we would often speak about how it's a positive and a strength to customize and tailor an intervention to your context. However, in this case, it actually had both negative and positive responses and really did show that discrepancy between the different stakeholder groups. Shared values and sense making. This was another important finding. It was at first difficult for me to understand why we were taking a business model that is strictly business and applying it to a service field. This shared values and sense making was particularly critical for the frontline staff, and how if we didn't have shared values between the complete organization, and it didn't make sense to how this could be applied to their daily care to improve patient care, it then served as a barrier to sustain this program in these healthcare settings. So the final part of this research really was about bringing each phase together. And that's where I came up with this sustainability being the tip of the iceberg. And the tip of the iceberg metaphor is really to conceptualize that sustainability is a small, often unrepresentative portion of something much larger or much more complex that we cannot see or understand. The purpose of the tip of the iceberg was to visually portray the complexity, observable and unobservable contextual factors and reasoning that triggered lean efforts to be sustained in practice. So if you can see there, engagement and empowerment, value congruence and sense making, the nature and process of implementation and that customization to context, how those things and the complexities within each of them shape that tip of the iceberg, the sustainability, and how it's hard to understand and unpack some of those concepts. So this three-phase research resulted in 3 publications, and I just wanted to share those for any of you that are interested in reading this work after. And I'm sure these slides will be shared after the presentation. If not, I'm happy to share with anyone. So that example was of lean, and my work now has evolved since then, where I'm doing a postdoctoral work on in sustainability on pain management in the neonatal intensive care units. But before getting into that, I really wanted to talk more broadly about sustainability research beyond the lean case example that I provided. So I wanted to touch on sustainability determinants, constructs, factors, theoretical approaches, evaluation, outcome and measures, interventions to enhance sustainability. These are often areas of questions for people. So work has been done in recent years to look at sustainability determinants and constructs or factors. So these could be the factors that facilitate or hinder sustainability. One recent review by Lennox in 2018 discovered that she did a consolidated framework of sustainability. So this was the first review that consolidated the evidence on sustainability. And she found that there were 62 approaches to either help sustain, so sustainability planning or evaluation. This included 32 frameworks, 16 models, 8 tools, 4 strategies, 1 checklist, and 1 process. So for example, the NHS sustainability model, the dynamic sustainability framework, these are different approaches to either help plan or evaluate sustainability. And she looked at all of these approaches and found that there were 40 constructs of sustainability. So that's quite a lot, and put them under 6 themes. The 6 themes were initiative design and delivery, negotiating initiative process, the people involved, the resources, the organizational setting, and the external environment. And out of those 6 themes, they're very similar to implementation. They aren't very different between implementation and sustainability. My challenge with this is, how do we take 40 constructs that has been consolidated across the sustainability approaches? How do we make that practical and applicable to practice to help health system leaders, implementers, and frontline staff do sustainability work? Another recent review looked at sustainability constructs across acute care settings, and they found 7 key themes, which was the innovation, the adapters, leadership and management, the inner context, inner processes, outer context, and outcomes. Another one that has looked at evaluation. So we've done great work in determining what influences sustainability. Where we're lacking is, how do we best evaluate that, and what are the outcomes and measures we should be looking at for sustainability? So it's all well and good to have these existing theoretical approaches and to know what influences sustainability, but how do we actually measure? What outcomes are important for us to measure? And then if we know the determinants, what are the interventions we need to enhance sustainability? So for example, we have knowledge translation interventions in existence, such as audit and feedback, or we have quality improvement methods such as learning collaboratives, PDSA cycles. We know about the use of these interventions in implementation, but what about for sustainability? Do we need them at the same degree and dose, frequency as implementation? So these are areas that need further exploration. We also need some work to understand the relationship between implementation and sustainability. My lean case showed to you how there is that connection between the efforts at implementation and that knock-on ripple effect for sustainability. We need to unpack that further to best address sustainability prior to implementation and to give the best effort to make sure the interventions we're implementing can be sustained. My postdoctoral work, I'm involved with the Impact resource. I'm not sure if you're familiar with this research. It's being led by Dr. Bonnie Stevens in Toronto. And I'm a part of this team to help with the sustainability of their research program. So their research program is developing an online interactive tool to improve pain management, assessment and management for neonates across Canada. And what I'm trying to help with is how can we evaluate the sustainability of that intervention in child health, and developing a framework to help guide their evaluation. And this is being done through both primary research and a review. So I've currently completed a review looking at evaluation and measures of sustainability of health interventions, and then trying to tease that apart to see if there's anything particular within the pediatric healthcare context. And this work is being funded by CIHR and WICRI. I'd like to take this opportunity to acknowledge the funders of this work, and also my supervisors, Dr. Shannon Scott at the University of Alberta and Dr. Bonnie Stevens at the University of Toronto. I believe I'm finished quite early, so I hope that I can invite some discussion, and if you have any questions.
There are a couple of questions already in, and here's my plug for encouraging folks to ask a few more. And I'll pose those 2 questions while we're waiting for others to type.
Perfect, thanks.
No worries. So from Shauna, what role should educating institutions play to prepare their students, disciplines in healthcare, for real-world execution of care? The need to integrate quality, resource consciousness, and accountability of these future healthcare providers.
Hi, Shauna, thank you for this question. And this question really actually excites me. And we have a publication on this of how it is the responsibility of our education systems to prepare, for me, in my experience, our nurses to be able to deal with quality improvement, these initiatives, these ongoing interventions in healthcare. And we need our nurses and other frontline healthcare providers to be able to address these and have that knowledge before they're qualified. And I think this was really shown as well in the lean example, because there's constant innovation fatigue. People are burnt out from constant changes and constant improvements, and they're educating themselves as they're on the go, whether that's at the side of their desk or within their clinical environment. So if we can prepare our healthcare providers to be able to deal with these real world contexts and situations, like you said, then I think that in a bigger picture will help for sustaining change and improvements in these environments.
Wonderful. Shauna, if you have any follow-up to that, feel free to type it in. From Stacy, just to better understand the challenges of the lean implementation, can you provide a quick summary of what lean is and tries to achieve?
Yeah, so lean came from the Toyota production industry, and it's all about reducing waste and increasing efficiency, and it has its own guiding principles and its own guiding philosophy on how to do that. So it's a very rigid, set in stone, I would say, approach, but it does have value. I want to make sure that is clear. I'm only presenting what these participants felt because of the implementation process. So the challenge with the context that I studied is that it just didn't make sense for them or resonate how you can take something that's used originally for automotive industry and apply that to healthcare context. Now, there is evidence out there of how it has been successfully applied in healthcare to improve efficiencies and reduce waste. So it can look at design of a unit and how to improve the design. It may look at where we're wasting time moving from getting equipment to going to patients. It'll try and reduce those wastes. So it has been shown to be very valuable in certain contexts. I'm just presenting how maybe the implementation approach in my research had an influence on sustainability.
Thank you. And Stacey as well, if you have any follow-up, just type them in. Shauna has asked for the reference, if possible, to the publication you suggested in response to her question.
Perfect. Yeah, I can share that after, but it is Flynn in Journal of Advanced Nursing, 2017. And I can share that.
Wonderful, thank
after.
you. We can post that on the Knowledge Exchange Network after the fact. Karen has asked, what's the role of credibility of the implementation team in sustainability. She says, it seems from the Saskatchewan experience, when funding for lean implementation ended, or it might be Sick Kids experience, the implementation strategy seemed to be diluted, but improved adaptation to context. Can you comment?
Yeah. So that adaptation to context, typically in implementation, that would be seen as a positive thing. And I, would see that from many experiences, like that example you just provided there, that you could adapt that then to the context and it would more fit and align with the values of the organization, of the staff. However, in the example that I showed, that dilution and that adaptation also meant less visibility that lean was in the environment, which made some staff and participants feel, I don't even know if we're doing it anymore. So that's that balance of the customization. In terms of the credibility of the implementation team, this was very important. One resistance, I think, even before thinking about sustainability, was that this was a mandated, top-down, being told that you are going to do this lean transformation. That's one thing, but it came from an external company who were not in healthcare and who were not from the Canadian context. I think that from the participants I spoke to also led to a resistance and shows how that credibility and that alignment with that implementation team, and also the importance of really having those who are going to be using your evidence-based initiative, whether it's lean or something else, how they need to be involved in the process.
Thank you. From Anne, I'm not sure how you measured sustainability of the lean process. Would you consider it successfully sustained or not? It sounds like there were a lot of factors that worked against successful sustainability, but is there any objective measure of it out of your example?
Yeah, so my research looks at more the perceptions of factors that increase the likelihood or hinder the likelihood of sustainability. The outcome of actual sustainment was not measured in my research, and that has been a part of Dr. Thomas Rodder's research and another team member in Saskatchewan. I don't have the name at the top of my head, but they did an economic and outcome analysis. So that work would show that. And the research to date that I've seen shows that, yes, there were some small wins, but on a large scale, there wasn't that sustainment that had been expected. But it should be clear that my research doesn't actually look at the outcome of, for example, how patient outcomes were affected long-term because of the lean transformation. Mine was about understanding the perceptions of those doing the work, doing the lean work, how they felt it was sustained or not.
Thank you. We have an anonymous attendee who asks what you would say are the top 3 factors that clinical leaders should focus on in a practice sense to promote sustainability.
Yeah, and you know what, this is the challenge, and this is the evidence we don't have. Like, it's just unrealistic that, for example, in this review I showed you, mentioned we have 40 constructs. It's unrealistic of how we can tackle in a clinical environment those 40 constructs. We don't yet know which are the key pieces to focus on, and if you do focus on those, how to effectively measure them and what interventions are needed to improve them. So I don't have a black or white answer, but I do believe as well that every context is different. So certain constructs or determinants will be important in certain settings, but not in others. For guidance, the best evidence we have at the moment is that consolidated framework and the 6 key themes within that framework. And that's what we're trying to work on now, is how we can distill those constructs and themes and get some form of evaluation guide that can be applicable in the healthcare setting. So I'm sorry, I don't have the black and white answer to that question, only those constructs and themes that we've consolidated through the Lennox paper.
Thank you. You talked of the resistance of practitioners to the lean initiative because it came from outside of healthcare. Is there anything that, if we were doing something similar again, we could front load to prepare people for how, to demonstrate how it's been successfully implemented in healthcare settings?
Yeah, absolutely. There are examples there, and I think it's all about how you message and translate that message. Applying it into the environments of those healthcare, of those pediatric cases, for example, that I looked at, would have been valuable. If you can't align with values and sense making from the very beginning, you're at an uphill battle then of how to break down any resistance. You know, change is inevitable. We do face resistance to change. That's just human nature. But how can we best come up with ways to tackle that? And in research, we found that sense making and that value alliance and the involvement of those frontline are three critical elements to that. And they're critical to implementation, which then have a knock-on effect to sustainability. So I suppose that does also address the previous question, you know, of those key things to focus on. Really, if it's not making sense, if it doesn't align with the values and you don't involve those that are going to be doing the work from the beginning, it does cause resistance for sustaining that improvement.
Thanks. Sometimes you have champions for your initiative or champions against your initiative. And sometimes those champions are powerful influencers in the clinical setting. Did you find that you had pro and con champions, and how working with them might make a difference?
Absolutely. And one interesting finding within this environment was that the pro champions were much more at the higher level of the healthcare system, so senior leaders and unit managers, frontline healthcare providers. There was the disconnect between that level and the frontline healthcare providers. Parents, interestingly, were supportive because they had been involved in the events and could felt a sense of being involved in the lean, helped them want to sustain these initiatives.
And forgive me for not remembering, were frontline clinicians involved in the initial conceptualization of this project?
No, it completely came from a political Ministry of Health mandate across the entire health system. So I looked at the Saskatchewan Health Region, but it was across the entire health system. And initial implementation focused on training senior leaders. So everyone had to learn what lean was and how to become lean leaders and lean trainers. So that was the focus at an implementation, which you can understand because the consultancy firm ended then, so they needed these senior leaders to know about lean. However, one challenge with that was that the participants I interviewed didn't feel involved. The frontline staff didn't feel involved at the beginning.
And as part of context, would family partnership on an initiative like this potentially help foster sustainability longer term?
Yeah, so to give another example, I'm not sure if you're familiar with the strategical clinical networks here in Alberta Health Services. I'm doing a lot of work with them at the minute across different initiatives outside of pediatrics and sustainability. And we've just completed a study, and 3 key interventions that participants felt really helped with sustainability was that co-design collaborative approach, actually designing and being partners in developing the initiatives that's going to be implemented, continuous monitoring and feedback, getting audit and feedback, finding out how are we doing, how is this initiative helping patient care or whatever the clinical issue is, and actually having patient stories, which was an interesting finding. So sharing how this initiative is actually impacting patients or their families, and hearing that back reinforced wanting to continue an initiative. So these are all key factors that are coming out in our research to facilitate sustainability. We need more research, like the question asked by someone in the group earlier about outcomes, and actually now linking these factors to sustained outcomes of the initiative.
Oh, thank you. One last question here, and if there's any others, I suggest typing them in now. How would something like COVID has changed everything about, or much of what we do? How does imposed issues from the external environment, which is COVID, as well as affecting clinical, impact our efforts around sustainability now? I know it's not part of your research, but we're all living
but
this
it does.
now.
Yeah, but for all of us, and it does make me think about this quite a lot. And if anything, I think it really shows that we more than ever need to build sustainable healthcare systems. We are struggling as it is to just keep aboard, keep our patients safe, keep our staff safe when we're faced with something like this. So we can't expect to be constantly overloading with change and initiatives. We need to have a system in place that can be sustained when we're faced with, a pandemic or just something of this scale. So it does absolutely affect, and it to me, we need to relook at how we're delivering healthcare and how we can offload the shoulders, I think, of those doing the work and trying to do their best by building systems and processes in place to more efficiently sustain improvements, rather than, this constant change, I think, that we're faced with. I think it's a system level issue, and how we can cross boundaries and reduce silos to better do that. So the SCNs is an example in Alberta, how they work together across these different strategical networks to build evidence-based improvements and to scale and spread them. So I think we need the embedding of science right at the front of practice to build these sustainable health systems. So, for example, implementation science researchers like myself working in partnerships with health systems to create efficient sustainability.
So we've got an encouraging comment from Anne. She says, this is very sobering because resource-intensive initiatives continue to be rolled out, perhaps without enough attention being paid to some of these sustainability promoting factors. In some cases, the change may actually be very valuable for improving patient outcomes, and in others, the change may not provide value, but in both cases, resources are invested. We need evidence for how to ensure these themes, if addressed, result in sustained best practice. And she says, keep on with your work, please.
Oh, thank you. And really the goal is, once you learn that, to then share that and spread that across to other settings, so that we're not constantly reinventing the wheel, that we're working together. And like someone said earlier, that should also be in the education environments and connecting that with the health system. They shouldn't be two separate bodies, really, for sustainable improvements. And like the last comment said, that's also very important, is that resources go into these initiatives that also may not be of value, and we need to learn that as well to make sure that we can de-implement that and not waste resources where they're not needed.
Absolutely. Learning from failure, and not failure in the complete catastrophic sense. But and Sarah says, I just wanted to share that in the past, lean processes were used at her workplace in a tertiary pediatric hospital. The overall feedback and perception of lean changes echoes what you've described, Rachel, in your presentation. It was a top-down, externally driven approach. Staff felt pressured to adapt, and the business or industry language and values were not always consistent with healthcare, so it was difficult to get buy-in. There were both positive and negative outcomes from her lean work, and sustainability was somewhat limited. Your work is quite relevant and timely. Something in the future approaches, she hopes to inform future approaches to change where she works through your work.
Thank you so much. And I think that shows, it's not necessarily, I'm not a lean researcher, and I'm not batting that, lean is a bad thing, but it's how you implement and how you approach any type of change or improvement with your in your healthcare environment. And I think one of the key messages I would say for any of you on here that are involved in improvement initiatives or implementing evidence-based research interventions into practice is that sustainability needs to be considered and planned for with those doing the work even before implementation occurs. That is critical for success of these initiatives.
That's a very good note to end on. Thank you, Rachel, for sharing your time and expertise with us. Thank you. All our members. You're very welcome. Thanks to all our members and other attendees for spending this time with us. We hope you depart with some practical knowledge to bring back to your organization. We have a packed fall Spark Live agenda. On Friday, September 24th at 11 Eastern, we're hosting British Columbia Children's Hospital, who present on their work with the Swish and Spit COVID test for school-aged children. Come learn more about it and their future plans. And on Tuesday, September 29th at 12 Eastern, we'll host another special COVID edition of Spark Live, More Than Medical, supporting NICU families with their transition home during a pandemic. To learn and stay up to date on all of our Spark webinars and other events and activities, please visit our website or follow us on Twitter at ChildHealthCan if you haven't already done so. Also, registration is now open for our annual conference taking place virtually in November. To register, visit the Children's Healthcare Canada website. It's always great if you watch live, as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Rachel for this wonderful webinar, and hopefully we'll see many of you back here on Friday. Thank you. Bye, everyone.